So today's speaker is Brendan Walsh, who is at the ESRI, with a secondary affiliation to Trinity, and he's talking on, well, see what he's talking on. So far away.
Thanks very much, Kevin. I was saying earlier, I asked to speak here today. I was here a few years ago, and I had a paper looking at the impact of under 6 GP visit cards and got some very good feedback. So again, this is the first time I presented this work, so feel free to question me throughout and offer me as much guidance as you want. So I work at the ESRI. Most of my research is looking at trying to inform the better planning of the health and social care system. And more recently, I started to focus a little bit more on social care and long-term care. So doing a little bit of work in terms of home support for older people, but also residential care, which is where this paper and the wider project falls into. So this is one of probably about 5 outputs ultimately, which will come out of a research grant from the HRB, which is looking at the sustainability of long-term residential care since the onset of COVID-19. Although realistically, we've been having ideas on sustainability in the sector, even prior to March 2020. As 3 key objectives. The first is to understand the impact the pandemic had on the system in a number of different ways. We had a paper published recently enough where we kind of showed in terms of mortality and cases, the different characteristics related with COVID-19 outbreaks in nursing homes. The second one here, active both in Ireland and internationally to help reduce the impact of COVID-19 in the residential care sector, specifically about funding. Funding is something that we've really worried about in this area for quite a long time. There actually isn't a huge amount of research, and we're trying to add to that. And then thirdly, building upon this work, other research in Ireland, but also international studies, what policies could we use to inform the sustainability of the sector when we have this new model of care for older people? So we are trying to keep people out of residential care as much as we can moving forward, or what residential care is now won't necessarily be what residential care is in the future. I'm going to spend a few minutes just kind of giving you a broad overview of residential care in Ireland. So when I say long-term residential care, I'm really talking about nursing homes. It's just not a term that's being used too much anymore in the literature. In terms of demand and expenditure, we spend about 2 billion per year on long-term residential care here for older people. The public component, we're spending about 1.4 billion, or between 5 and 7% of the HSE budget on long-term residential care. So it's an increasingly important part of expenditure within the HSE. And the HSE is also unique in an international sense because it has an integrated both healthcare and social care, unlike many other kind of European countries. Recently, the figures show that there are about 32,000 individuals at any moment in time using residential care. About 31,500 of these would be over the age of 65. So we have about 4.2% of the over 65 population using residential care. And to kind of put the sector in a wider context, there's a lot of discussion about the public hospital system. So every year we use about 3.4 million inpatient bed days within the public hospital system. They're not necessarily equitable to residential care, but in residential care, you're talking about closer to 12 million beds. So it's an increasingly important part of the health and social care system. It's dominated by the nursing home support scheme, also called the Fair Deal scheme. So it was the first, if not one of the first, areas of health and social care where statutory funding was introduced in 2009. So if an individual needs or requires residential care for various needs, they're over the age of 65 or they have a higher threshold under the age of 65, they will receive funding from the state to receive this care in nursing homes. So everybody who is entitled to it should in theory receive the care in a timely fashion. We've spent about 1.5 billion per year on this scheme, with about 70% contributed by the state. The remainder then comes from the residents themselves. It's a mixture of income and assets to determine how much they would pay for their care. And essentially, if an individual wants to enter a nursing home in South Dublin to live in South Dublin, there's nothing stopping them going to South Dublin or to Roscommon or to Donegal or other parts of the country to receive this care. The scheme covers public and private homes, both for-profit and not-for-profit, and it's administered by the National Treatment Purchase Fund. There's a huge array of organisations involved in residential care in terms of regulation, payments, administrating different schemes, and I go through them over time. Again, I'm not going to get into it here, but the amount of different organisations involved, I do think, is an issue when it comes to the future sustainability of the sector. In terms of provision, despite being majority state funded, the private sector is now the main provider of residential care. There's been a big shift since about the year 2000 towards the for-profit sector. But 17% of beds are public beds, so they're mainly within HSE owned and operated nursing homes. But again, the Royal Hospital Donnybrook would also be considered public here. But 9% of beds come from the voluntary sector, the non-profit private sector. This is mainly homes owned by religious orders. So, for example, the Sisters of Nazareth are one of the biggest providers of residential care in the country. And then about 3/4 of all long-term residential care beds are in for-profit nursing homes. Now, in the past, most of these for-profit nursing homes would have been independently operated and owned nursing homes. You think of your small rural nursing home, but increasingly private equity funded from outside of Ireland, very much outside of Ireland, are now the key providers. So about 50% of all long-term residential care beds are now funded, are now in nursing homes funded by private equity. A kind of interesting tidbit is that the biggest provider of nursing home beds in Ireland is actually now the French state. So previously, Orpea, which is the global leader in this area, was the largest provider of beds here. They started investing it into Ireland in about 2016, 2017. They essentially went bust during the COVID-19 pandemic due to issues in terms of providing adequate care to their patients. They're a French company, so the French state took them over. I always find this a little bit of an interesting area. But again, it's a very dynamic area when it comes to provision and supply. There's large geographic inequalities in terms of supply across the country. We have no resource allocation mechanism when it comes to health and social care in this country. In places like Kildare, Meath, Louth, South Dublin, you have very good supply. In more rural areas, the supply is much lower. And in terms of the dominance of the private sector, again, it varies hugely across the country as well. I'll try to show you that in a few moments. HICWA is the regulator of residential care for all residential care, essentially. So in order for an individual centre to provide care for older people, they have to be registered with HICWA, and they're subject to regular inspections. And if needs be, HICWA can suggest that the nursing home itself needs to be closed down.
I remember the head of, I think it was Age Action Ireland, years ago told me, says if you're worried about nursing home access, become a Protestant. Then you get much better access. Seriously?
Maybe, possibly, I'm not too sure. Like there's certain nursing homes, for example, that are kept for specific groups in the population, like maybe retired nuns or priests. I'm not too sure about that. One. Yeah, there's one here. This is in Carna in West Galway. It's called Quishfarga, Ars Quishfarga, and it's only for Irish speakers. So there's about 558 nursing homes currently in Ireland. The purple here are these private for-profits. The orange, which might be hard to see, are these voluntary or nursing homes. And then green here are your HSE or your public nursing homes. You can see around here in UCD, sorry, this doesn't work. If I click it, the slides go away. So around here in UCD, there actually is quite a lot of voluntary and public nursing homes, but most of the time in Dublin and the Greater Dublin commuter belt, it's dominated for the private sector. Not going to get into this again too much. This is kind of just to give you a background to the study itself. But again, these large providers of care, which operate between 3 and 10 plus nursing homes, now constitute the largest providers of long-term residential care in the country. Okay, so moving on to a bit more background in terms of COVID-19 in residential care. There's been a number of different books written about the pandemic in Ireland. There's one book by Richard Chambers, The State of Emergency, and there's 2 chapters which are dedicated to nursing homes. But the book itself is reasonable. The 2 chapters are actually excellent in terms of giving you an idea of the harrowing experience that the nursing home workers, the residents and their loved ones had to go through, especially at the beginning of the pandemic. The nursing home sector, the long-term residential care sector, was disproportionately hit by the pandemic. Across the first year, about 2/3 of all nursing homes experienced an outbreak. In the first year, there was over 8,500 cases amongst residents, over 6,000 cases amongst healthcare workers or workers within residential care facilities, and over 2,100 beds attributed to COVID-19. We had a paper which came out a few weeks ago, and it identified, and again, this is quite consistent with international literature, that local community COVID-19 rates were the key determinant to an outbreak in long-term residential care. And just to put all of those numbers into kind of a more bite-sized piece, in the winter 2020-21, just before the kind of vaccination came into being, on a daily basis, there was a 1% probability on a daily basis of a nursing home having an outbreak if they're in a county with very high rates of COVID-19. So it was extremely difficult to keep COVID-19 out of nursing homes. Another key factor identified is nursing home size. And again, if you're to interact size and local community COVID-19 rates, really it was very difficult to keep it out of certain nursing homes. But interestingly, there was no link found across ownership type. So we didn't find that public nursing homes or private nursing homes were more likely to have a COVID-19 outbreak or a more severe outbreak. During the pandemic as well, there was a clear rationale to try and help providers. There was real worries and concerns about the viability and the resilience to providers to COVID-19. In most countries in the OECD, there was substantial government interventions for healthcare providers. Most of the supports were very similar to this Pride Relief Fund here, part of the CARES Act, where essentially, in terms of the amount of aid given to a nursing home, it was very similar, regardless of the characteristics of the nursing home, but it varied across how big or how small that nursing home was. The CARES Act here, it distributed just over $7 billion within the first 2 years to long-term residential care providers in the US. I'm going to come on to this second program in a moment, in a bit more detail, but the US also brought in a pay-for-performance program. They allocated $2 billion to this program over a very short period of time, and I'm going to show you in a moment why that was the case, where they tried to match performance in terms of low COVID-19 rates to the amount of funding a nursing home received. Internationally, there isn't a very large literature on the impact of these relief funding measures for long-term residential care providers, but in general, it did seem that these relief funding did mitigate financial deficits to residential care homes. There was less insolvencies and revenue losses during the pandemic period than there actually was prior to the pandemic period. But it seemed that nursing homes are using the funding, at least in the United States, to invest in workforce as opposed to better capital investment in health infrastructure. In some areas like California, there was actually a much larger increase in profit margins during the pandemic than there was prior to the pandemic. So there clearly was inefficiencies in terms of disproportionately targeting those nursing homes which needed the most. So there's good evidence from the United States that those nursing homes which might have been smaller in rural areas or looked after more disadvantaged group actually saw less of an effect from these different relief funding. Going back to this pay for performance in the last slide here, the quality incentive program. A research paper which came out last year actually found that 94% of all the funding for this went to nursing homes that experienced no COVID-19 infections at all. So it's quite clear that this pay for performance approach didn't work to mitigate the impact of COVID-19 within the residential care sector. And most of these 94% actually were in rural counties, in rural parts of the United States, where COVID-19 wasn't an issue at all. Yeah.
That's a different interpretation to mine, which is that it worked really well.
So the way the program was set up is that you took the county average rate of COVID-19. If you were below the rate across nursing homes in that county, you received funding. But only nursing homes, or the majority of funding went to nursing homes that were located in counties where COVID-19 wasn't really an issue. So in places like New York, you received no funding, which, going back to kind of the first few slides here, your local community COVID-19 rates are a key reason why you would have COVID-19 in residential care. If the local community COVID-19 rates were zero, you were being rewarded by the state for that. So there's no evidence that it kept COVID-19 out of it, but there's clear evidence that it was allocated to those areas which weren't really affected by COVID-19 as much as more urban areas. Yeah, that kind of makes sense. Yeah, it seemed to be poorly targeted in terms of performance. So one of the schemes which is quite similar to this provider relief fund from the CARES Act was initiated in Ireland, called the Temporary Assistance Payment. It was introduced in April 2020, so about a month after COVID-19 really started to take off. And it was introduced to extend financial assistance to private nursing homes, so for-profit and not-for-profit nursing homes, to address the additional costs arising from COVID-19. This did not target or public nursing homes. They received funding directly from the state. We don't really know how that funding was used. We don't have any information on public nursing homes in this one. It lasted up until actually recently enough, but in general, most of the funding was, let's put this back on here. Most of the funding lasted until June 2021. So in this period of time, about 123 million was provided to private nursing homes through this scheme. It was a substantial investment. So if you were to take this investment per population at 65 plus, it's quite similar to the investments made in the United States at the time. It's closely linked to the Nursing Home Support Scheme, and it was administered by the NTPF. So eligibility for this was based upon you having an NHSS contract, but the vast majority of private nursing homes do. And we were able to follow 437 for-profit and not-for-profit eligible long-term residential care homes during this April 2020 to June 2021 period. In terms of practicalities, it was designed not to be too arduous. The nursing homes themselves had to verify that they were regulated by HICWA. They gave some information on their bed occupancy, and also that they were actually a viable entity at the time of asking for funds. And claims were mainly made retrospectively for itemised expenses. It was broken into two different elements. So the first is the standard assistance payment element, and the second is the outbreak assistance payment element. For the standard element, this is how the funding was broken down per resident. So you receive €600 per resident per month for the first 40 residents in your nursing home, 300 for the next 40, and then 150 for each subsequent residence. The outbreak assistance program was put in place then for post-outbreak months. Effectively, there was a cap of twice all of this. So if you were claiming, say, 20,000 on this, you would claim 40,000 potentially overall, or up to a maximum of 60,000 in a specific month. And the idea, at least argued at the time by the HSE, was that these payment caps would allow the operators to decide which of the elements of the scheme was more important, the standard assistance payment or the outbreak assistance payment. The claims forms themselves detailed a lot of information in terms of where the funding went, but practically you could break it down into non-pay categories. There's 2 non-pay categories and 4 pay categories. We aggregated the claims into cleaning and infection control for non-pay categories and a residual, some non-pay other. And then for pay categories, we aggregated into nursing, which is mainly overtime nursing or additional nursing, healthcare assistants, again, overtime or additional staff, or agency staff, so hiring staff from an agency to provide the care. There was a small residual when it came to pay categories here, might be for things like porters and so forth, but it was so small we didn't actually include it in our final analysis. So the research questions when it came to TAPS was, well, firstly, was TAPS associated with better kind of COVID-19 outcomes? Going back to the point I was trying to make a little bit earlier. So we'd use 2 outcome measures here. So the probability of a COVID-19 outbreak happening beginning in a specific month, and then the severity of the outbreak, which we measured as the percentage of residents infected with COVID-19. We then sought to analyse the characteristics of TAPS users. So are larger nursing homes or smaller nursing homes or private or for-profit nursing homes or not-for-profit nursing homes more likely to use TAPS? In terms of the COVID-19 outbreak itself, so were nursing homes using it prospectively or retrospectively? How big of an impact did having a COVID-19 outbreak have on TAPS use? I'm not going to get into the final point here, but future part of this research is to see, can we learn anything from this in terms of funding mechanisms? So the TAPS data, in addition to providing the level of TAPS funding by category and month, we also had information on the nursing home itself, the name of the nursing home, the address of the nursing home. We could then match it to other sources. We had information from the HPSC in terms of COVID-19 outbreaks. So we had the nursing home ID, the outbreak ID, the day of the first and the last COVID-19 case, the number of cases, the number of deaths, hospitalizations, etc. But importantly, we only have this up until March 2021. And then in terms of COVID-19 in the community, again from the HPSC, we have information on outbreak cases by county and by day. We aggregated this up to the month level. We've used a number of different resources then to get a handle on nursing home characteristics. So the main one is the HICWA bed register. So they're the regulator of long-term residential care. And then the nursing homes themselves will provide information on their name, their address, their size, the registered operator, and so forth. And we were also able to merge information in terms of NHSS payments per month, whether they're for profit or whether they're part of a wider operator. We merged all of these data together and we have a balanced panel of just under 6,000 long-term residential care home months. I say balanced because it's quite a dynamic area. So you have some nursing homes closing either fully or temporarily or opening fully or temporarily during this period. They're not included here.
Why not?
It was very difficult. So it's very difficult based upon the HICWA bed register to know when a nursing home is actually operating. So you know when they're registered, but you don't necessarily know the month in which they're operating. So if they're registered in March, they may not necessarily start operating until May, and we would be including them as zeros in terms of taps for the 2 months before they started operating.
It's not necessary to have a balance panel. From a financial point of view.
No.
Balance panels, cool. Yeah.
But it was just, we just didn't have the information on those nursing homes opening and closing.
There's about, I think you said, there's about 250 nursing homes in the country.
There is, in this panel here, there's 437.
So you're talking maybe 30 or so might have closed, maybe.
So I think it's something like 19 closed, 13 opened. And then post-COVID, there's been about 40 closed, yeah.
The exclusion of those could bias your estimates. So if I'm a referee for this paper,
Yeah.
look up the future observer to see what day it closed in Carthage.
Yeah.
Because if these are closing because you need that.
Yeah. No, that's a good point. Like in terms of other sources here, we use local newspapers to decide some of this. And I'm going to get back to your second point in a second. We have information on occupancy at a point in time. We don't know the occupancy at each point in time. So when I said earlier, we have information to some degree on payments per resident, we don't have the denominator for each month. We've kind of the denominator at the beginning of the period as well. Yeah. But that's a good point. Like we've done some robustness checks here to see whether or not using taps or the level of taps used led to you closing subsequently. We're not really finding much, but the issue with that is the numbers are too small for us to make any precise estimates. So some quick descriptives. So across this period, there was 123 million spent. And you can see in terms of total payments here, and apologies for the NAF Excel color still, this is kind of fresh off the press. You can see that for total payment, it's highest at the beginning. It kind of reduces over time. But then in winter 2020, 2021, when we got a big spike in COVID-19, there was a spike in TAPS payments. And in terms of residential care homes themselves, again, it started out quite high. The top number here should be 437. Here. So in terms of the whole period, there's no point where less than 85% of nursing homes were not using some forms of TAPS. Okay, so it was actually, if you were to think of success in terms of uptake, it was clearly there was a success in terms of uptake. I don't necessarily think that's a success, but that spin has been put on it. In terms of our then 6 categories, cleaning and infection control is the main category, especially at the beginning. But then in terms of nursing, healthcare assistance, non-paid other and agency, we're still talking about a reasonably large amount of money across the whole period. And there clearly then is fluctuations across months when it comes to each category. Not the majority, but about 40% of all cleaning and infection control happened within the first 4 months of the scheme. And then after that, it kind of bottomed out and is quite similar to levels in terms of healthcare assistance pay, nursing pay. For nursing pay here and healthcare assistance pay, I think it's quite linear. So, and I'm going to show you in a few moments, there's very little fluctuation in terms of using TAPS for nursing and HCA based upon COVID-19 outbreaks, but there's a practical reason for this as well. But the opposite then is in terms of agency pay. So we know that there's high rates of COVID-19 at the beginning, high rates of COVID-19 in this period here, and agency pay in terms of TAPS increased considerably. The left-hand side here are months where there was no outbreak in a nursing home. The right-hand side is when there was an outbreak open. So it's not just the first month, but maybe subsequent months as well. And you can see that for most categories, there's reasonably large increases in months where there is an outbreak. but especially for agency pay, getting back to what I'm after showing you a few moments ago. And there is essentially a maximum possible payment per nursing home based on how large they are. So firstly, if you were just to follow the blue lines here, the top box is months with no active outbreak, if you can see it at the back. The bottom box is months with an active outbreak, but you can see as nursing home bed size increases, there's a slight downward trend when it comes to payments per person made in months with and without an outbreak. But for these smaller nursing homes, the difference between the maximum possible payment that could have been made and compared to the bottom, there's quite a variation here in terms of the potential funding that was available to them. Again, going back to your point, this number here is occupancy at the beginning. We don't necessarily know how many residents were in nursing homes at any point in time. There's a slide at the very end, but realistically, there wasn't as many outbreaks among smaller nursing homes as larger nursing homes, but so this is not necessarily a reduction in residents due to deaths, but it's likely a reduction in residents due to not actually using long-term residential care more generally. A lot of people stopped using residential care during this period.
Just one more quick point.
Yeah, go ahead.
Can you explain the 2 points? The top graph towards the right where the payments are more than the maximum?
A little bit. So it appears that in a month, in some months they have gone over, in the following month they somehow made up for that in terms of lower amount of payments. But theoretically, you should have seen no blue line over the arms.
Does that can affect your estimation if they're shifting around when you're claiming this?
Yeah, potentially. Like we've ran a few different robustness checks and everything seems to be quite similar, but yeah, that's something we kind of worried over. But I wanted to also be transparent around the difference between all of this. And again, it's possible, and we've no information on this, these larger nursing homes might have seen a slight increase in capacity since the beginning of the COVID-19 pandemic. So they're kind of the descriptives, and now getting into the statistical analysis in a bit more detail. Sorry, I'm running behind time a little bit, but the first outcome we care about is the probability of a COVID-19 outbreak happening or beginning in a nursing home in a given month. The main variable we care about is obviously TAPS here, and we run separate regressions for C. So we run 6 separate regressions for each category. What I'm going to show you today, I have no kind of overarching TAPS regression, so to speak. Everything is kind of run across the different categories. For TAPS, based upon what we've done previously and what other individuals who've looked at these relief funding is, we've put them in at a lag. So in order to determine whether or not using TAPS prior to an outbreak, to see whether or not there was a kind of a prospective way in which TAPS was being used. But also, just from a practical point of view, there's a lag in terms of delay, in terms of funding and benefits potentially accruing from TAPS itself. We've also included COVID-19 rates at a lag, again, following the literature. It was less likely to the nursing home itself became a key point in expanding COVID-19 out to the wider community. The nursing home itself was often the last institution impacted by COVID-19 in the local area. So the direction of travel, at least when it comes to COVID-19, seemed to be into the nursing home rather than out of the nursing home. So including COVID-19 rates in the previous month seems to make more sense here. And we've some other information in terms of for-profit status, size, beds, etc. But really, for the next few slides, I'm just going to focus on the TAPS payments.
This is a panel.
It's a panel.
And what estimator do you use?
So here, this is just a very simple logistic regression, cluster standard errors. We haven't run any panel data analysis here. Okay. So there's no fixed effect included here for each nursing.
Okay.
Yeah. And again, a logistic regression for a similar outcome, but instead of using TAPS in a binary sense, we're going to use TAPS amount per bed. So giving you the potential payments per resident for the nursing home to see if that had an effect. To make things a little bit easier to interpret, then we broke this TAPS amount divided by beds into tertiles. Again, it didn't really matter too much, but at least from my point of view, I think it's a little bit easier to interpret. I got critiqued recently enough in a paper for including a lot of these odds ratio graphs, because I think they're easier to interpret instead of tables. So for this presentation, I hope you agree with me. But these show the odds ratios of the different categories for TAPS on the left-hand side, and then the tertiles for TAPS on the right-hand side. And the outcome is still the same, so the probability of a COVID-19 outbreak happening. You can see that for most of the categories, I'd say all of the categories, there's no statistically significant results. But for cleaning and infection control, it does seem that by using cleaning and infection control in the previous month increases the probability of a nursing home having an outbreak in the subsequent month, which to me kind of makes sense, especially at the beginning of the pandemic. A lot of the residential care homes were not set up sufficiently with good cleaning and infection controls in place. If that was the case, they were more likely to have a COVID-19 outbreak. And I think by spending a lot of taps on cleaning and infection control, especially at the beginning of the pandemic, might have increased the probability that a COVID-19 outbreak occurred. But do you agree with me or not? I'm not too sure. And again, across each of the other categories, there seems to be no huge effect going on. Then on the right-hand side, this is for TAPS payments for those who took out any TAPS across each category. And again, I've broken into tertile, with the lowest tertile here as a reference group. And there's very little variation for each of the different categories. However, for nursing, it does appear that having higher rates of TAPS use for nursing is related to slightly lower odds of having a COVID-19 outbreak in the subsequent month. Okay. In terms of the size of the different regressions here, they vary between 2,500 and 3,500 observations. Second, then, to look at outbreak severity. So for this, we use a proportion variable, so cases per resident or cases per bed on the left-hand side. Based upon what we undertook in terms of our analyses and some of the previous literature, it didn't seem appropriate to use a simple linear regression. So we include a fractional rank regression, a GLM with logistic link function and binomial distribution, following a paper Norma coded a few years ago. And again, our right-hand side remains the same. We use a binary variable for TAPS category, and we use a levels variable in terms of TAPS amounts per category. The numbers are much, much smaller here. So one of the questions maybe I have for you today, so N here is 235. To what degree we'll actually find anything in terms of statistical significance, I'm not too sure. But again, it does appear that there's very little impact of using TAPS prior to an outbreak in terms of the severity of an outbreak, in terms whether or not that's a binary TAPS use or the levels of TAPS use on the right-hand side. On the right-hand side, then, it's percentage point differences on the x-axis. The third outcome, then, is to try and get an understanding of whether or not having a COVID-19 outbreak impacted your use of TAPS subsequently. So we've essentially swapped the right-hand side and the left-hand side variables of interest here. So again, it's a logistic regression, first of all, so the probability of using TAPS on the left-hand side. But now we have a very simple dummy of whether or not you had an outbreak of COVID-19. And then at the bottom here, we bring over our TAPS amounts by beds, put in its natural logarithmic form, and we run some linear regressions. And we do this for 4 months. We do it in month T-1, month T plus 1, and month T plus 2. I'm going to focus on the outbreak results first of all, again using my nice, I hope, nice odds ratio graphs. You can see that the blue here relates to T-1. So this is saying that having an outbreak in month T, on the right-hand side, the impact that has on the use of TAPS for cleaning and infection control, non-payment, nursing, HCA, and agency in month T-1. And for most, again, except not for cleaning and infection control, there doesn't seem to be much of an impact in T-1. But as an outbreak occurs, those nursing homes that have an outbreak increase their use of TAPS subsequently, and especially for agency pay in month T plus 1, and then if it reduces over time as the impact of the COVID-19 outbreak deteriorates. Again, this isn't too surprising from our point of view. This here then looks in terms of, the first one's TAPS use and the second one, sorry, here is TAPS payment. So on the left-hand side now, we have the amount of TAPS payments per resident. And again, it follows a very consistent relationship to what we saw previously. So having an outbreak increases the amount of TAPS that is being used across cleaning and infection control, other non-paid categories, nursing, HCA, and the largest effect is what we're seeing for agency. The effect isn't quite as large for nursing and healthcare assistants in either this graph or this graph here. That's because if there was an outbreak of COVID-19 in a nursing home, not only were the residents affected, the staff themselves were affected. So you didn't have as many staff to to pay overtime to. Essentially, a lot of these staff had to go home, they had COVID themselves, and you were replacing them with agency. So on the right-hand side here, a lot of the variation in terms of the size of the effects is simply explained by using staff from agency to make up from the reduction in staff that you already input. Two tables to go here. So going back to these regressions, instead of just focusing on whether or not the nursing home had a COVID-19 outbreak, we look at the other nursing home characteristics, and all of the regressions here are undertaken in multi. So again, you can see for the COVID-19 outbreak, it increases the probability of using TAPS, but also larger nursing homes in terms of operator size, larger nursing homes in terms of the number of beds, increased the amount of TAPS used. Having higher rates of community COVID-19 in the community didn't necessarily reduce the use of TAPS. It did for non-pay other, and we think this is because when we dug a little bit deeper, even though PPE wasn't necessarily meant to be used for TAPS because it was already being supplied by the HSE, there was a lot of increases in the use of TAPS for PPE following the outbreak of COVID-19. And then finally, the larger nursing homes also appear to have the biggest effect when it comes to agency pay as well. So larger nursing homes were about 2 times more likely to use TAPS for agency than smaller nursing homes, even controlling for COVID-19 outbreaks. And again, in terms of TAPS payments on the left-hand side, instead of a binary variable here, you can see a slightly different effect. The size of the nursing home in terms of whether it was part of an operating group, the size of the nursing home in terms of whether or not it was had larger number of beds, doesn't appear to have too much of an impact on higher use of TAPS payments. And even getting back to the point I made a few moments ago, for a nursing home, there's a negative effect. And a negative effect also for agency. So there does appear to be a slight difference in terms of the probability of taking out TAPS in general, but once you take out TAPS, there's much less of a variation across nursing home characteristics, amount of payments that were made. Okay, so I think I'm slightly on time, gone through this quite quickly. Very simple conclusions we've taken so far from the paper. We think it contributes to the nascent body of literature on financial relief for long-term residential care during the pandemic. Positively, it was quickly and widely used by long-term residential care homes. We spent a lot of money on the scheme in the first 14 months. And for most months, the vast majority of eligible homes used TAPS for some type of payment. Larger nursing homes, large operator groups had higher use, despite the tiered structure of the TAPS payments itself. And then TAPS had no prospective impact we found on COVID-19 outbreaks or outbreak severity. Again, this is probably unsurprising. The terms of reference for TAPS wasn't necessarily to reduce the impact of COVID-19, it was to provide more funding to nursing homes to make them viable and sustainable over time. And COVID-19 outbreaks themselves were associated with higher TAPS use, especially for agency. I think that's me, Kevin.
Thank you.